Hello, and welcome to our webinar today. I'm Amy Hannes with the Ardmore Institute of Health, home of Full Plate Living. We are excited to have Dr. Bonnet with us today. Hi, Dr. Bonnet. Let me introduce, I wanted to read a quick bio on Dr. Bonnet. He is a board certified in family, sports, obesity, and lifestyle medicine. He's an associate professor at Stanford University School of Medicine and program director of the medical weight loss at Palo Alto VA. He completed his undergraduate and medical school degrees at Ohio State University, family medicine residency at Duke University, and sports medicine fellowship at the University of Florida. He also holds a master's degree in public health from Harvard. So thank you again, Dr. Bonnet, for being with us today. I am going to pop off screen and hand it over to you.
All right. Well, thank you so much, Amy. And it is definitely a pleasure and honor to be here with you all. I'm excited to share some of my knowledge and experience with some of these new blockbuster drugs that I'm sure you're getting plenty of questions about with your patients. I've been in a fortunate situation where I've gotten a lot of experience using them. So hopefully I have some wisdom I can distill and share with you all. Like she said, I work at the Palo Alto VA. And I'm a clinical associate professor affiliated at Stanford. And just to be clear, the views and opinions expressed here do not reflect either of those organizations. But anyway, we have a lot of stuff that I'm going to try and cover succinctly and hopefully in a way that's going to be useful to you clinically. So I put a few objectives up here, but yes, go Buckeyes in the chat, Talisha. So I'm just going to do a couple slides just to get everybody on the same page with these GLP-1, GLP-RA medications, and then talk about sort of the role in obesity, and then sort of about risk benefits, average weight loss, things like that. And then also focus a lot on the clinical pearls. I know many of you are probably prescribers of these, and so hopefully that will be a really fruitful discussion at the end. And I'm happy to take questions as well, so you can put them in the chat too. So let's just start with just getting the basics so we're all on the same page here. And again, this alphabet soup, this GLP-1, which stands for glucagon-like peptide, which is the native hormone that's produced in the intestinal L cells, primarily in the ileum and colon. But then we also have the GLP-1 receptor agonists. So that is the pharmaceutical version of the medication that is designed to mimic that hormone and bind to the receptor. So a slight differentiation there. But in terms of the effect that these medications and this hormone has, there really are systemic effects all throughout the body in many different organ systems. So when these were designed, and they're actually from the venom of the Gila monster initially, so we can thank nature for these. But these were initially designed as diabetes medicines. So they were primarily targeting the liver to decrease glucagon and hepatogluconeogenesis, and then also to increase insulin from the pancreas and improve beta cell function. So I highlighted those diabetes effects in blue. What they found was there was a pretty impressive appetite suppressing effect, and then thus a bunch of weight loss that they were seeing in the trials. So this is probably due to the central effect on the brain, but also there are some effects within the GI system. So it decreases gastric emptying and also colonic motility as well. I think it's important to note here too, since you were all prescribers of this, one potential side effect here, you see that there are actually receptors even on the heart. And so it is a chronotropic agent, meaning that heart rate can be increased sometimes with these medicines. Usually the average is only about 4 or 5 beats, but some people can have up to a 20 beat increase in heart rate. So something to just be aware of when you're seeing patients who are on these in clinic. But for today's discussion, our focus is really going to be on the weight loss effects. And so again, the primary mechanisms we're worried about are the effect it has on increasing insulin, decreasing glucagon, again, impacting the gastric empty and colonic motility, and then the appetite suppressing effects on the brain. And just to note that there probably is both hunger and also some thirst suppression as well, which is going to matter a little bit as we get into some of the side effects and potential challenges that these medicines may create. So the important thing here is to understand, well, what is the role with these medications in obesity? Obesity is arguably the largest epidemic and problem that we face in medicine and as an industrialized society. And so these medicines are probably going to be here to stay, but I think understanding the role that they should play is really important. And again, I'm not going to get into all the ins and outs of obesity, but suffice it to say, it's a quite complicated disease. We've learned a lot, but still probably feel like we know almost nothing. What is clearly true is that there is a genetic component, but our environment and also our lifestyle choices clearly have a large influence as well. You can read different studies that have different estimates. What I say to simplify things is it's probably 50-50, right? Most genes are not determinate for obesity, but in the right setting, which is our highly obesogenic society in the United States, all of the unhealthy foods and ultra-processed foods and lack of activity and stress and lack of sleep and all those things certainly then exert their effects on our genes, creating, this vicious cycle and this terrible disease. So it's not that it's all one thing or the other. It's usually a combination of both. And so it's not to say that this is everyone's fault, but I think it also should recognize that we do all still have a role to play. And certainly, I think focusing more on making healthier choices, default choices, is an important one. But when we think about treating this clinically, and that's sort of my day job, seeing patients one-on-one, the Obesity Medical Association basically targets obesity treatment on a foundation of lifestyle medicine, which I think is super important for everyone to understand because we don't want to skip over the basics. And so physical activity, healthy diet, behavior change, those are foundational to anyone who is trying to attempt to lose weight, whether you're using medicines or not. Now, these are the pillars of the Obesity Medical Association. So on top of the lifestyle medicine, you have adjunctive medications and bariatric surgery when appropriate as needed. So again, these are all things that you add on, not that you replace something else with. And when you're thinking about using these different tools for treatment, it's good to have goals and strategies of what you're trying to accomplish. So typically with weight loss, you're really trying to reduce all of the other comorbid conditions that come along with it that really do cause lots of health problems. And so this is a nice summary of the general health benefits you'll start to see when you lose different amounts of body weight in someone with overweight or obesity. So the more weight you lose, typically the more benefits you get. But from a clinical perspective, we typically will shoot for 5 to 10%. That's historically been where it's sort of that sweet spot where it's doable, feasible, you get tons of benefits, and hopefully you can maintain that weight loss over time. So you can see you get everything from cardiometabolic benefits to joint pain, quality of life, even reduced mortality and reduced costs. So this is a real entity with lots of widespread systemic issues that really does matter when we can help people effectively lose weight and keep it off. Now, the nice thing about this 5 to 10% goal is that if you look at most of the literature, in general, good lifestyle programs can help people lose about 5 to 10% of body weight. And so that's a great clinical target, and it's usually achievable by patients in the first year. Now, it is important to note that individual results vary. So some people can do extremely well with lifestyle changes. Other people can really struggle a lot. And it's not necessarily that somebody's doing something right or wrong. It's just their physiology is probably different. So I think it is important to be very understanding and empathetic and compassionate. Losing weight is hard, and lots of those people have experienced a lot of shame and guilt throughout their lives. So I think being supportive and understanding is really helpful from a clinician standpoint. The good news with lifestyle changes is that in general, they're probably a bit more durable than what we've seen with the weight loss medicines. So about 2/3 of the weight that people lose via lifestyle can be kept off after they've lost that initial weight, which again is what we really need in the long run for overall health and well-being. Now, when you compare lifestyle with the other treatment modalities, again, you see lifestyle alone is the 5 to 10% we just talked about. If you add medications, and this is really primarily because of the new medications, average weight loss is about 5 to 20% of body weight. So historically, the medicines have only been about 5 to 10%. So the new GLP-1 class has really changed the focus on medications just because they're essentially 2 to 4 times as efficacious as what we had previously. So that's why this has become a big deal and become very popular. Contrast this with lifestyle plus bariatric surgery. And again, the numbers vary, but 20, 25 to 30% is about the average weight loss post-surgery. Historically, it's been the most efficacious way to lose weight, but it comes with plenty of risks and potential issues long-term as well. The other important comment I'll make here when you're treating obesity, you'll notice that lifestyle is part of all of the options. So whether you use medications or whether you use surgery, you are still going to need to incorporate lifestyle changes to be successful long-term, which I think is something we definitely want to emphasize with patients. And lifestyle can start now. You don't have to wait to have surgery to start your lifestyle changes. In fact, if you want to have a successful surgery, do well on medications, the lifestyle stuff should really start first. And they've literally baked this into the prescriptions. So if you look at the package insert on the GLP-1 receptor agonists, it quite literally tells you they are only appropriately to be prescribed as adjuncts to dietary changes and increased physical activity. So I've highlighted that section for you, but it makes it abundantly clear that this is how we should be using these medications appropriately in patients. So people always want to know how much weight they're going to lose. How many pounds am I going to be able to get off and keep off? And that becomes a really important question. And so I'm going to share 2 studies with you here. And again, today I'm going to focus on primarily semaglutide and tirzepatide because those are the newer agents and those are the ones that we're seeing a lot more weight loss with. This was the New England Journal paper with semaglutide. And what you'll see here on the graph on the left, the blue bars are the semaglutide. On the y-axis, it's the percentage of patients who lost certain amounts of weight. The x-axis, you see the categories of weight. So there's greater than 5% body weight, 10%, 15%, and greater than 20%. Now there's three really important take-home points here. The average weight loss with semaglutide was about 10 to 16%. I think that's an important point. The second point is what I've circled in red here, is that some people can start to do really well on these medications. So about a third of the people lose more than 20% of their body weight. And again, that's basically starting to get into bariatric surgery territory. So for those people, these drugs seem to be pretty miraculous in terms of what they're able to achieve, particularly when lifestyle is generally in the 5 to 10%. Now, the other comment I'll make clinically, since I see a lot of patients, is that you also notice that about 1 in 12 people basically lose no weight on these medications. So they are not a panacea. They do not work for everyone. In fact, I have plenty of patients who lose 0 pounds or almost nothing, despite being on these medications for months and also trying to do the lifestyle changes too. So they don't work for everyone, but for some people, they do seem to be particularly good. Now, if you look at the Tirzepatide data, which again, similar kind of design as the one I just showed you, and this is over a year, by the way, a year and 4 months with semaglutide and a year and 6 months on Tirzepatide. But if you look here, the one major difference between semaglutide and Tirzepatide, one, the weight loss was a little bit higher with Tirzepatide, but interestingly, they had to add a whole nother category of body weight loss on the bottom. So instead of just being greater than 20%, they had to add greater than 25% of body weight, which is clearly in the bariatric surgery range at this point. And about a third of the people were able to achieve that. So this is really, really impressive from a medical standpoint. Even if you're not a fan of the meds or the drugs, I mean, you have to acknowledge that the fact that we're now getting as good as surgery is really impressive. So just a quick summary of both of those medications sort of side by side, the average weight loss, how many people seem to be doing really well on each one of these medications, how many patients lose almost nothing, which even with Tirzepatide, it's about 10% of patients. But then also the cost, which I didn't put on the previous slides. These things are super expensive, and very few insurances actually cover them. They're very, very expensive. The VA does cover them to a degree for patients, which is really fantastic. And now we've been able to use a lot more of them. But if you go out to Blue Cross Blue Shield or Aetna or United or Cigna, you're really going to have patients paying lots of money out of pocket to get these. And so that's $1,400 or $1,100 per month. And we're going to talk about how long we think people need to stay on these things, but it probably is a while. The last comment I'll make here about those graphs I just showed you, I mean, that's really a lot of weight loss. I mean, almost 20, 25% of your body weight is a ton, and that does not happen overnight. So again, misconceptions about how quickly people should be losing weight. It's really on average about 0.5 pound to 2 pounds a week. Again, if you add that up over the course of a year, it's 52 pounds. So because these trials are so long, I mean, 68 and 72 weeks, there really is just a lot of time to be able to lose weight. And the difference between these medicines and the old medications, people are just able to lose weight a lot longer. If you look at the older oral medicines, people typically lose weight over the first handful of months, and then they sort of plateau and peter out. So that's the big difference, is that people can seem to continue to lose weight for a much longer period of time. Now, one other thing I'm going to share about Tirzepatide, which I think is super fascinating and something we should probably pay a little bit more attention to here. They did another trial with Tirzepatide that basically said, well, what if we, instead of giving you the medication and have you, try and exercise and improve your diet, what if we really focus on that first? So this actually had a run-in to the randomization, meaning that the first 12 weeks, you didn't get drugs. Everybody was in the same protocol, and they were basically trying to lose at least 5% of their body weight before they got any medications or placebos. And so you can see in this graph here, they lost about 7.5% of their body weight doing lifestyle changes alone. Fantastic. Now what happens is then they either get randomized to placebo or drug. And you can see if you get the placebo, you basically kept off 2/3 of your weight doing your lifestyle changes, which is exactly what we would expect. But if you then added the drug after this robust lifestyle program, you can see that you ended up losing almost 25% of your body weight. So the average weight loss with Tirzepatide was 21% in the other trial. If you do lifestyle first pretty intensively and then add the drug, you basically get an extra 4% of body weight, or a relatively 20% increase in overall weight loss. So it would be good to see more data of stuff like this, but that to me at least suggests that maybe we want to make sure that people really are getting the lifestyle habits right first, and then add the medications when they start to have more challenges or struggles or plateau. The other comment I'll make here, and I didn't talk a lot about liraglutide today because it's one of the older medicines, but they did something very similar comparing it with lifestyle. And they basically, again, did that 8-week run-in where they put people on an 800-calorie diet, and then they randomized them to one of 4 groups. So they either gave them a placebo, they gave them liraglutide, or they just put them in a sort of supervised exercise program, or the supervised exercise program plus liraglutide. You can see what the body fat changes were here. I think the interesting things to note is that exercise basically did as good as liraglutide. Now, liraglutide is probably not as potent as the other agents, but the fact that exercise did equally well is still really impressive. But obviously, combining them all together, you got the best benefit overall. And certainly, we care a lot more about body fat than we do just body weight in general, because you really want to prioritize fat loss, not lean mass or muscle mass loss, which we're going to talk about here in just a couple minutes. So not only are people worried about how much they're going to lose, but then also there's concern, well, what happens when people stop them? How much weight comes back on? And sorry, that number got a little moved here. But basically, in the semaglutide trial, we have a really nice publication that followed all those people for a year after they came off of the medicine. So once the trial was over, everybody stops the drug because it wasn't FDA approved for weight loss at that time. And so you see what happens here pretty quickly. People regain basically 2/3 of the weight that was lost. So 17.3 to 5.6%. Now, the interesting thing is, though, if they actually did something else unique, they published it by body weight loss category. So the next graph I'm going to show you is the same data from the initial graph. It's just broken down by whether you lost less than 5%, 5 to 10%, 10 to 15, greater than 15 to 20, or greater than 20% of body weight. Now, the interesting thing is that if you didn't lose more than 15% of your body weight to begin with, you basically ended up back at the same weight that you started at after the 68 weeks of being on semaglutide. So that is a really important point. If people are just trying to use these medicines to lose 5 or 10 or 5% of their body weight, they're probably not good strategies unless you're willing to take it indefinitely, because all those people gained all that weight right back. Now, the other potential issue is that the people who lost tons of weight, this only goes out 1 year. So we don't know what happens at 2 years or 4 years. So there definitely is a concern that there can be a lot of weight regain that happens if people come off these medications, particularly since there was no strategy for them to keep it off. I mean, the trial just ended. They didn't walk away with a robust lifestyle program. They just said, sorry, no more drug. Good luck. We'll see you later and let us know what happens. So again, just important to think about when we're thinking about or having conversations with patients about, is this a good medication to consider and use? And there are plenty of side effects with this too. I'm sure you all are aware of some of these. Some of them have been published in the media. What I would say is I listed the most common ones out here for semaglutide and tirzepatide. Again, I put up the placebo group because it's always good to compare the placebo to the active drug to see how common the side effects actually were. The semaglutide group is in blue, and then the tirzepatide is in black. So you can compare apples to apples in each. The take-home point here, nausea is super common. I'd say clinically, nausea and constipation are the most common things I see in patients. If you get people up to a high enough dose, they will feel a little nauseated. It honestly is probably a little bit of an appetite suppressor. So a little bit of nausea can be okay and tolerable. Too much nausea gives people vomiting, makes it so they can't eat or drink anything, is really not good. But you see most of the side effects are GI related. And tirzepatide does seem to have a better general side effect profile than semaglutide. I cannot explain that exactly, although I'm sure it has to do with the GLP molecule itself. And tirzepatide is a dual agonist, so it also has a GIP effect in addition, which may impact some of these side effects too. But again, lots of GI side effects that patients are typically going to see. Now, the nice thing is there are lots of lifestyle things you can do to help correct some of those problems that people are getting with the medicines. So I mentioned at the beginning that little bit of thirst suppression as well. So making sure patients stay plenty hydrated is really important because they may not be getting those same hunger and thirst signals because of the medications. And that certainly can help with headaches, constipation, dizziness. And then, I told you constipation is probably one of the most common things I see that really causes lots of challenges for patients. And so making sure they get plenty of dietary fiber actually becomes even more important because, again, we are reducing overall calories in people's diets. And so they actually have less calories to work with, which means you need a relatively higher amount of fiber within the calories you do have. So a diet like full plate living is fantastic to use with patients because it gives them lots of that good dietary fiber, lots of fruits and vegetables and produce that's also high in water. So that can be a really good strategy. And then even things like acid reflux sometimes can occur with these medicines, again, because you're getting such a delay in gastric emptying. So the stomach, things are just not moving food through as quickly. And you can get acid reflux if you lie down too early or you're eating meals that are too large. So those can be some other good strategies to use. The media has reported about potential suicidality with these medications. And what I can tell you is as of January, the FDA actually published this report, and they basically looked at all of the adverse events people had reported with these medicines, and there does not seem to be a causal link that they could identify. There was no greater risk of suicide with these medicines versus other obesity medications. So as of now, we have no data to say that that is actually true, but we should obviously be mindful and thoughtful of that when we are prescribing it with patients if they do have any unusual mood changes. One of the things I mentioned a little bit before was this idea of body fat versus body weight loss. And unfortunately, most studies are just body weight, and they don't really differentiate between muscle mass or fat or anything else. And so historically, when people have lost weight, doing normal lifestyle measures, people typically lose about a quarter for like every pound. About 75% of it is fat mass, and 25% of it is typically lean mass. So you really don't lose pure body fat, and you really don't gain pure body fat either, because the muscle mass and lean mass basically have to support any fat mass that you add. So it's never going to be 100% either way. I guess my last image doesn't show up here, but the bottom row in the slide basically shows you that with the new weight loss medications, with semaglutide, they did a subgroup analysis on patients with DEXA scans. And they showed with the DEXA scan that potentially up to 40% of the lean mass lost was coming per pound. So that means 60% fat mass, 40% lean mass loss, which is very problematic, particularly if people are losing high amounts of weight over time, and you're going to lose, an extra 15% of muscle mass. That's really going to cause significant problems to metabolism, overall function, fitness, etc. So prioritizing lean mass is a big, big concern when people are trying to lose weight, because it really will make it much harder to maintain their weight loss if they don't have it long term. The good news is there are some lifestyle strategies for this too. And so, most of this data does not come from studies with the medicines because they're too new. But when people are typically trying to lose weight, the ways that you can help optimize their lean mass maintenance during those phases is to, one, increase protein intake. So you're getting at least 1.3 grams per day of protein, and then giving the body some sort of stimulus, which in this case is usually strength training or resistance training. So not only do you need the substrate, so you need to have the amino acids to actually build and maintain muscle, but then you have to have a stimulus to tell your body what to do with it. And that's where the exercise component is really important. And, for here, many of our patients certainly struggle with developing a safe program that they can do. So we often have them work with physical therapists. We have tons of medical fitness professionals too, that patients can get referred to, and they can be really valuable in designing a really robust program that helps patients exercise safely and maintain a lot of their muscle mass and improve their function. The last side effect I'll comment on here, this data actually came from Morgan Stanley, so this is not in a peer-reviewed journal, but Morgan Stanley is obviously very interested in following the money, so I have to believe that there is some validity to this. But they basically looked at consumer habits and how they were changing when people started taking these medications. And I've boxed in red here the two things I would highlight is that, one, a really positive thing about these medications is people actually seem to start eating healthier. So they actually start consuming more fruits and vegetables, and that's denoted by the light blue bar on the top there. Or you're at least saying the same, eating more weight loss friendly foods, eating more lean proteins like poultry and fish. And excitingly, the dark blue line basically shows that people are eating less salty snacks, cookies, sodas, sugary drinks, confections, and even decreasing their alcohol, which there have been some reports about that too. So to me, this is super exciting because that means these agents have the potential to help with effective lifestyle behavior change. So not only are you suppressing appetite, but we're actually encouraging people to adopt those healthier behaviors, which are historically hard to do. So I think this is a potential really great application of these medicines, is to help people make those changes so that they can establish them as habits that will carry them through long term. The other comment, I didn't put this table up here, but they also looked at what people were doing eating out wise, and people reported eating about 75% less fast food and pizza when they went out to eat. So again, another really positive thing here, that maybe we're changing consumer habits, which hopefully will drive businesses to change their offerings to be more healthy as well. So lastly, I'm going to end with the prescriber tips and titrations. I know many of you are going to be in this role, and so hopefully we have some good clinical wisdom to dispel to you all. And again, the first thing I just want to reemphasize here is that we are really clear with patients that these are just tools. They are not panaceas. They are not singular answers. They really do need to be combined with lifestyle changes to work well. And again, all you're really doing is primarily just decreasing hunger. You are not giving them health and vitality, right? They need to make sure that they're getting the nutrients they need, the exercise that their body wants, working on managing stress, sleeping better, all of the challenging things that really improve health and vitality. The analogy I'll give to some of you, because I think historically I certainly had a different perception of weight, was that it was this static thing that didn't change, and that once you got to a new level, you could sort of remain there without too many problems. And what we clearly see is that weight is like most other chronic conditions. So if you compare it to hypertension, if you have a patient comes in whose blood pressure is elevated, you start them on amlodipine or losartan or whatever your drug of choice is, they come back and see you, and you say, great, your blood pressure is controlled. And then you give them a refill for a year for that medication. And so the whole idea is not only do you need the medicine to decrease their blood pressure to a safe level, but then they need to continue taking that medicine to keep their blood pressure at that new safe level. And weight really is the same way. Whatever intervention you're using, whether it's medications, a diet, activity, surgery, you must keep doing whatever the intervention is if you want their weight to maintain at that new level. This is why when people go on diets and they go off of the diet works while they are on it, they lose weight, but there's only so much weight that that diet is going to let them lose. And then once they go off of that diet, that is how weight regain happens. So we really want to try and avoid that with patients. So you want to have a consistent support system for them and some sort of intervention that is taking that place to help them not just lose the weight, but then keep it off. So for some people, that means staying on the medications. For others, hopefully it means adopting much healthier lifestyle practices that enable them to maintain their weight. I'll just make one quick comment for the prescribers here again. There are some contraindications to this. I mean, I really only see one absolute contraindication, which is a history of a personal or family history of medullary thyroid cancer or MEN2 syndrome. Obviously, don't give people drugs that they have hypersensitivity allergic reactions to, but those are the only absolute contraindications to using it. So relatively safe for most people. There are some relative contraindications or warnings, and that's, we typically will not prescribe this medicine to patients who have had pancreatitis of an idiopathic origin. So if they've had gallstone pancreatitis or alcoholic pancreatitis or got stung by a scorpion, as long as the offending agent is removed, we will be willing to give the medications. So if they've had their gallbladder taken out, they're no longer struggling with alcohol, and they're not exposed to scorpions chronically again, we would still give those patients the medication if they were interested. There is a caution about diabetic retinopathy. And again, it's not that you can't give it to patients who have it. It's just you need to monitor it closely, particularly the first handful of months that people are on it. The concern is that sometimes with these agents, there's been a worsening of the retinopathy, which is thought to be due to the significant drop in blood sugar. And there can be some gallbladder disease as well. Again, anytime people lose a lot of weight, it can cause gallbladder stones or other gallbladder issues. So just being mindful of it, again, not necessarily avoiding it, but making sure you're aware of it if patients choose to start them. Now, in terms of the titration, it can take patients months to titrate on these things. So you don't just start these and everything is good. We typically are seeing patients back quite often and have nurse check-ins to make sure things are going okay. But you can see here, I mean, it takes 5 months to get through the full titration of semaglutide and onto the main dose. It takes 6 months to get all the way through all of the different dosages of tirzepatide. Now, oftentimes patients don't need to go to the higher dose, but it is important to realize that this is going to take a lot of visits and massaging to actually get somebody fully up to the maintenance dose that they might need. I didn't put liraglutide on here. It's an older agent. The titration for that is you can increase it 0.6 milligrams every week to a 3 milligram maximum. I think this next slide is really great. So if you do want to take a screenshot for future reference, I think this is a good one. This basically was from clinical experience. So my colleague, Michelle Hauser, put this together. I made a minor edit to it or two. But basically, it sort of lets you compare and contrast the potency of the different agents that are GLP-1 receptor agonists that are approved for weight loss. We did put Ozempic on there, which is for diabetes. But again, I think it's helpful to see what the different dosages do. So you can see, the maximum dose of liraglutide is equal to about half of the maximum dose of Ozempic, which is probably why you see about, 2/3 less or about 25% less weight loss with liraglutide. And you can see Wegovy, even then, it's probably the max dose of that is a little over half the max dose of Tirzepatide, which is, again, probably why we see some additional weight loss with Tirzepatide. So one of the interesting things you can do, there is crossover between the agents, so you can switch between them. So we've had a lot of shortage problems, so we have switched patients from liraglutide to semaglutide, or from semaglutide to Tirzepatide. So you can actually kind of do that without having to start over which can be a helpful clinical thing to do for patients who might need it. And then lastly, just a couple pearls for you to take home with today. So what we try and do is not necessarily go exactly by the script of titrating every month, no matter what is happening. The goal really is to titrate patients so that they are losing weight gradually. You do not want to shut their appetite down completely. That puts them into complete starvation mode and actually will completely disrupt their overall weight loss trajectory. So you want some appetite suppression. So again, they can work on all those lifestyle changes, but not too much of it. And you don't want the side effects, certainly. So I have patients, I've literally kept them on, the 0.5 milligram dose of semaglutide indefinitely, and they've lost tremendous amounts of weight. So we do really want to try and personalize this a little bit to the individual. Some people do need higher doses before they see any benefit. So again, I think there's just a lot of individual differences that we want to be mindful of. And again, you're trying to titrate to effect of some mild to moderate appetite suppression with the goal being fat loss / weight loss. So whatever dose works for that is the dose you should use. You don't need to try and get people all the way to the top for any particular reason otherwise. And then again, the goal really is sustainable weight loss, not for them to lose 30 pounds in 30 days. It's to have gradual weight loss over a long period of time that is sustainable. And again, the way we approach these is like they're chronic medications. So the discussion I have is, are you willing to take this medication for life? Because it is possible, if you want to keep the weight off that you lose, you may need to continue using the drug. Now, obviously, my hope and our hope is that patients can transition off of it if they have robust lifestyle changes there supporting them, but it does not always happen. And we have seen lots of weight regain from patients who just said, well, hey, I'm not using this anymore, I'm good. But you really don't want to set the expectation of, hey, I'm just coming to take this drug for 6 months and then I'll be fine. What we see in those situations usually is that patients will lose weight and then they can quickly, within months, regain all the weight they lost, which is really not what we want to try and do with patients for sure. And then lastly, don't forget the lifestyle changes. I think I've emphasized that enough. But again, great resources like Full Plate Living, which is free for patients. I know many patients in our clinic struggle to afford things like dietitians and healthy food. So it's wonderful to have a free resource online that basically anyone can access anywhere. Again, I think I emphasize the importance of protein and resistance training so people can maintain the lean mass. But again, this is about overall health in general. And those are going to be components whether or not you need to lose weight or not. And then the last thing, I'll just leave you with it again, some helpful behaviors that the literature has sort of identified as what are the things that people do who lose the most weight and keep it off. So this is from the National Weight Control Registry. So this is people who, by definition, lost at least 30 pounds on their own and kept it off for at least a year. Not surprisingly, they work out for an hour pretty much every day. They're very good about eating consistently. They eat breakfast. They eat a relatively lower calorie, low fat diet, which really is a predominantly plant-based diet. And they also track their weight. So they keep an eye on their weight. And I think this is maybe one of the most important things they do. They catch slip-ups quickly. So it sort of gets out of the all or nothing thinking. It's, wow, I had a bad day or had a bad weekend or, I went on vacation. But instead of a day turning into a week, turning into a month, turning into 6 months, they get back on the track right away. So it's a couple days, a couple meals, no big deal, back on the program. And so I think that's one of the most important things for people being able to be successful in the long run. So just to summarize quickly here, again, wonderful tools we have. I think it's a really exciting time for the field. And I think we're going to see a lot of innovation. And there's like more than 70 of these drugs in the pipeline for development. So these are going to be here to stay, barring some horrible side effect we discover. But they really should be used alongside lifestyle medicine. They are not replacements for it. Again, we talked about some of the side effects, some of the weight gain, weight loss, and weight regain. And then also just the importance of potentially using these as agents to help people live healthier lives, not just to get them to eat less food. So the last that I'll leave you with, and this is my public health background speaking, but I really found this quote and found it quite lovely. When a flower doesn't bloom, you fix the environment in which it grows, not the flower. And I spend a lot of my time in obesity medicine fixing individual flowers. But I think obesity really is a public health problem. And it's because we have designed a society that is optimized for unhealthy living. And so I think we can sort of wrestle with that and come to consensus that we really do want to invest in ourselves and in the health of our world. I think we're going to really struggle doing individual approaches for everyone. These drugs are great, but they're never going to replace the health of the public and giving people sort of the vitality and wellness that they all deserve. So with that, I will take questions. Thank you all for coming and listening.